So I'm hoping today to give you guys some information. It's actually really humbling to see that this many people turn out just to hear what I have to say. So I'm hoping that when you leave here, in addition to the packet, that you could take 2, 3, 4 tips, go home and start a program that you can use to treat your knee pain. And for those of you that are a little bit further along that path, this might give you some more information on where you may be headed. My staff has probably heard this a whole bunch of times, and for those of you that I've seen that are my patients, I have all my analogies. You hear enough?
No.
Okay. We'll adjust it. And if you can't hear, let me know, and I'll stay behind the podium, just so everybody can hear. Yeah, that's turned up all the way. And then at the end, we're going to have time for questions. So anybody that's got questions, I'm hoping I'm pretty good at getting through stuff. Got it. Jeff's going to follow me around and hold that up. But I'm pretty good, I think, at the end of, let me just do this. Is that any better? No. That's okay. I'm usually pretty good at the end where people say, once they look at their sheet of paper and they go through 1, 2, 3, 4, 5 and say, oh, you answer them all. So hopefully that's the case. But if not, we have plenty of time. So let me just go through here. So here we are, and like Jeff was saying, so I went to college on the East Coast, did 2 years at Muhlenberg, which is a small private college in Allentown, and then finished up at SUNY New Paltz and did a lot of biology there. And then back to where I was born and raised in Philadelphia, did my medical school internship residency at PCOM. I was lucky enough to get into a fellowship here and did an entire year here just of hip and knee replacement surgery with the docs that were here. And I was really taken aback and it felt very privileged at the end when they offered me a spot. So this was an easy no-brainer. When I went home, my wife and I, we were looking for places all over the country and said, do you like it here? You want to spend the rest of our life here? And she said, yeah, this is really nice. So she loves it. My kids love it. You know, they get spoiled by all of the different things. You know, every time we go away, they think there should be a SeaWorld and a Legoland and a zoo and a Disneyland all within driving distance, but they get to live here. So I've been here since 2006. Predominantly doing hip and knee replacement. And this is probably one of the big questions that I get asked. So what is a DO? Where I grew up on the East Coast, I heard there was a Philadelphia person there. A lot of people, Philly, New Jersey, tons of DOs. When I grew up, my doctor was a DO. My orthopedic surgeon was a DO. So we do our 4 years of college and then a 4-year medical school. The main difference is more the philosophy looking at the body as a whole organ system, not as individual parts. So if you have a stomach problem, it may also lead to back pain. So we're trying to focus on you as a person, not just the one organ that has a problem. So they really focus on the musculoskeletal system, which I think really leads itself to help you become an orthopedic surgeon, because for 4 years, you've learned about all the intricacies of the musculoskeletal system before being subspecialized. But what's interesting, and I found out a lot of people don't even know this, in California, a lot of MDs actually were DOs by training, but there's a whole issue, Prop 22 in 1961, and I forget the exact, it had something to do with the billing and insurance and Medicare, but they switched everybody over. So if you were a DO, you sent the state $65 and you became an MD. And that's what happened. So UC Irvine actually was an osteopathic medical school, and for reasons to change over the degree, they sold it and it became, for $1, became an MD school overnight. So this is the goal tonight. I'm going to talk about knee arthritis. We're going to talk about what it is, how do you treat it, and then beyond that, if you need a knee replacement, what is it, what happens, and we're going to go through some of the details. So arthritis, I get asked all the time, what is arthritis? Do I have rheumatoid? Do I have osteo? So osteo, bone, itis, inflammation. So osteoarthritis in its general terms is an inflammation of a joint, and it's typically due to loss of cartilage. Rheumatoid arthritis is different. It's still pain of a joint, but it's a systemic disease. These people are born with a disease that affects all of their joints. It destroys the joints, and it works on both joints symmetrically, both right and left, where osteoarthritis, it's not uncommon to just have one bad joint and the rest of the joints in your body are okay. So basic anatomy, because I'm sure everybody has been on the internet, everybody has a friend, and everybody knows what a meniscus is, but there's a whole bunch of other stuff inside the knee. So the kneecap, what we call the patella, that is actually a bone within the tendon. It serves as a pulley system. So not only does it protect the front of your knee, but it makes your quad muscle stronger. so it can straighten out your leg and it acts as a fulcrum. The thigh bone, or the femur, that's capped in cartilage. So if you look up here, the cartilage, that's what typically goes away with arthritis. And you also have a 3 millimeter cartilage cap on the top of the shin bone here. So 3 millimeters of what we call articular cartilage. That's the cartilage that's smooth, that's shiny. It almost looks like a hard-boiled egg when you look at it. But between those cartilages is the meniscus. The meniscus is another type of cartilage that acts both to cushion the knee, and it stabilizes the knee from going forward and backward, secondary to the ACL. So that's the second most common thing I find that most people know about in the knee. The ACL, they've all heard of sports players injuring their ACL, and the second one's the meniscus. But they both serve a function to stabilize the knee. When you get arthritis, typically it can just be a wear and tear. More commonly, someone injured their ACL or someone injured their meniscus years ago. They may or may not have had surgery. But when you lose the structure that supports the knee starts to microscopically slide around. And when that does, it starts to wear down the cartilage. So what you start to see, I don't know if that's coming up on the white as much, but what you'll see is the cartilage starts to wear away. So you lose that 3 millimeters of cartilage, and now you have exposed bone. So when you stand, it hurts. When you bend and straighten your knee, it hurts. And when you start to do things, those are the things that cause the inflammation and the swelling. So I threw these in here. I hope you like them. My staff, I'm sure they've heard every one of my analogies. But what I found is over time, these make sense to people. Most common question I get, why does my knee make noise? When I stand up, it cracks and crunches. Everybody in the room hears it. So this was the best analogy that I've used, which helps you understand that if you drove your car down the street, it's asphalt or concrete. The car doesn't make much noise. The tires are running over the smooth surface. But now there's a rumble strip. It's still asphalt or concrete, but it's irregular. So as your car goes over it, it wakes everybody up that was sleeping in the back seat. And that's what happens with your knee, because as you bend and straighten the knee, the cartilage is irregular. So when you get up from a squatted position and you put more force on those little cracks and bumps, it goes snap, crackle, and pop. So it's not a bad thing. Sometimes it smooths itself out so it will go away, but that's what's going to happen when you stand up and that knee cracks and crunches. Now, who gets arthritis? This is the other common question that I get from a lot of people. When am I going to get it? Who's going to get it? Baby boomers, our biggest generation right now as far as population. So in that age group, you just happen to be lucky enough to be in that peak of when people get arthritis. Older patients also get it. And we have lots of patients that are living longer. I have lots of patients that I operate on that are in their 90s. They're healthy, they're playing golf, they're playing tennis, and then their knee deteriorates, and they don't like their quality of life. So these patients are starting to just get wear and tear after being on this earth for 90 years. Post-trauma, these are my youngest patients. So the 40, 50-year-olds, these are people that had a fracture or a bad injury at some point, damaged the cartilage at an early age, and now they have a progression of arthritis. So they have the arthritic knee of an 80-year-old, but they're 45. We treat them the same. And obesity. Obesity epidemic is a huge reason that we're starting to see lots of health conditions and health problems, but it does affect arthritis. So what do you feel? Any of my patients that have been in, they'll see I have half of my intake form has a whole list of adjectives because everybody describes it differently. So I hate to say, what kind of pain are you in? It's better to say, what sort of symptoms do you have? Because a lot of patients tell me, I don't have pain. I have instability, I have burning, I have giving way. So there's all sorts of things that people will feel. So none of them are wrong. And you may not have all of them. And you may not have all of them at one time. You might have one this month and another one next month. So don't worry about it. Don't try to figure it out. It is what it is. So you're not going to fix it by trying to predict the symptom. But it will come and go. And these are some of the things that you may have already seen. This, I think, explains a lot. The reason I get all the time, patients come in and my knee gives way. Why did my knee give way? What's wrong with it? What's unstable with it? When we as surgeons look at a knee, there's an instability that we perceive based on your exam. So if I pick your knee up and you fell and you had torn your medial collateral ligament, I would describe that as unstable. So the structure on the inside of your knee, a strong ligament that's supposed to be sturdy, when I bend your knee, it bends in a way it's not supposed to. Yeah. That is what we would call instability. But a lot of people have a stable knee, and they describe their knee as being unstable. And what happens is that when you step on something, the tack is my best example. So if you were barefoot, and you were over there, and I said, hey, come on over here, I want to show you something, and you were barefoot, walking slowly, and stepped on the tack. Most people, before their brain recognizes, ouch, that's a tack, that tack's sharp. And if I put full weight on it, it's going to hurt a lot. Before any of that happens, your brain says, hey, that hurts, I'm going to shut your leg off. And your quad muscle reflexively gets weak, and you fall to the floor. So your knee's not unstable. There's nothing wrong with the actual mechanism. It's a pain generation thing that bypasses your thinking. And that's what happens in the knee. So when your knee hurts and you step or turn or twist wrong, your brain says, hey, that hurts. I'm not going to squeeze anymore because if I do, it's going to hurt. So your knee gives out. So that will happen. I'm sorry, I can't predict when. Yes, you might fall, so be careful if this is one of the things that you notice. But the more that you're aware that it is a possible thing and the more that you notice that it can happen, makes you a little bit more cautious in certain situations. Now, x-rays, this is a big thing. So we will examine knees, and a lot of times without an x-ray, I can tell if someone has arthritis or not, just by what their knee exam is. But when we look at an x-ray, what you're looking at here is on the right side, you'll see a pretty normal looking knee. That's the patient's left knee. So when you come to the office, we always set the x-ray up as if you were the doctor looking at the patient. So your right is the patient's left. Pretty normal looking knee. You see the end of the thigh bone, and that space, which is equal between the thigh bone and the shin bone, is the cartilage space. So 3 cartilages. Cartilage on the end of the thigh bone, 3 millimeters thick. Cartilage on top of the shin bone, 3 millimeters thick, and then a meniscal cartilage in between. So on the left, the patient's right knee, that's a severe arthritic knee. So they've lost all the cartilage space, both on the thigh bone and the shin bone, and the meniscus at this point is shredded. So that's why everybody with arthritis has a meniscus tear. But these are the meniscus tears that we don't care about because you're bone on bone. The meniscus tear is obsolete at that point. People will also get bone spurs. So the bone spurs that you see on the side, those are the bumps that people will feel. And when those bumps happen in the back of the knee, that's why it hurts for people to bend. They go to bend, and the knee won't bend all the way. So this is similar to a trailer. So if you had a boat on a trailer, the wheels spin, but when you get to where you're going, you put some chock blocks in front and behind the tire, and that trailer doesn't move. And that's what can happen to an arthritic knee. You go to bend it, and it just doesn't bend like the other knee. It's because those bone spurs are in the back and blocking it. So do you need an MRI? No, you don't. Don't ask your primary for one. You don't need it. It's a lot of times a waste of your time to get it. There's very, very few instances where we need it. So an x-ray is the way that we diagnose arthritis. Everybody with arthritis has a meniscus tear. And a lot of times we see the bruising of the bone. You can see all the white on the left. That's white fluid because there is no cartilage left. It's gone. So by the time that you wait 3 weeks to get it approved by your insurance, sit in the MRI scanner for 45 minutes, wait for your primary to call you back, and then show up at the doctor's office, we look at it and go, you have arthritis. So a lot of times the x-ray is a better option. We do use it if someone falls and we suspect they have a fracture. So that's one indication with arthritis where we would use an MRI, but an MRI is not typically needed for arthritis. There was a study, Wayne Goldstein, that I know in Chicago, and we did one here recently, just a year ago. We were curious, but patients that I saw in the office, these were patients here that had knee replacement that were referred to me for knee replacement. 42% of those patients showed up with no x-ray, but almost 35% of them had MRIs. So we can actually do the less expensive, better test for arthritis before you kind of run through the mills. So I just try to use that because a lot of people think the MRI is the better test, and it is for a back if you're looking at a disc herniation, or a younger patient that you suspect has an ACL tear. But it's not something that we need for an arthritic knee. And the other important thing too is the x-ray and how it's done, because when you stand, people notice if their knee's getting bow-legged or knock-kneed. When you lay down on a table and you get an x-ray, you don't see that. So when people go to the ER or their primary and they get an x-ray, you can be your best advocate and say, hey, I think I should be standing, because we want you standing. Because the standing gives me the alignment. This is an x-ray of a patient that had her x-ray only 2 months before I saw her lying down. So you see that one x-ray on the left. It looks pretty good. So the primary is trying to figure out why she's hurting. I can't remember if she saw the primary or the ER. And the radiologist reads it and says minimal arthritis. But the patient was in horrible pain. And she's wondering what's wrong with her knee. So I had her stand up and do one x-ray, and you can see she's bone on bone. Completely explains her pain. So if you ever get an x-ray for arthritis on your knee, just remind people and say, I think I should be standing for this. It's going to show better what your knee really looks like. And everybody's talked about this. We talk about meniscus. Everybody knows about a meniscus. Everybody knows about an ACL. Everybody else knows about a Baker cyst. Probably the most common thing that people know about in the knee, second to the meniscus. But it was first described by Sir Morton Baker in the 1800s. He noted the swelling in the back of the knee. And what they found back then is even if you cut it, lance it, operate, and their surgeries and antibiotics weren't anywhere near like ours today, I think 3 or 4 of the patients in a series had amputations because they got infections. But what he realized is that it's not a cyst like in other parts of the body. We have cysts that develop, but this is truly a swelling of the back of the knee due to your arthritis. So when your knee's swollen, the path of least resistance in some people is out the back, and you'll have a fullness or a pain back there. So we can't take it out. It's not a separate structure. It's just some people get swelling in the front. Nobody has a name for that. That's knee swelling. Some people have swelling in the back. That's called a Baker cyst. So you treat it just like you would treat swelling anywhere in the knee. Compression, ice, elevation. And it's important to know that if you don't have any reason not to, you can take an anti-inflammatory. But this way, if that happens to you, I hear it all the time. People are in pain for weeks waiting to get in to see the doctor or go into the ER. So start treating this right away. You can wrap it, you can ice it, you can use anti-inflammatories, and some people find in 24, 48 hours, they're already feeling better. This is not what we do here. So there's lots of ways around the world that people treat knee arthritis, and we've come a long way. So things that we can do. There's an academy, our American Academy of Orthopedic Surgery comes out with guidelines for every indication, every diagnosis, every surgery. This is the brief view of their guidelines for treating knee arthritis. Top 3, anybody BMI over 25. Weight loss is a huge thing. For every pound that we carry, that is about 4 or 5 pounds of pressure on your knee joint. So if you lose 5 pounds, you just took 25 pounds of pressure off your knee. That's an entire backpack. If you hurt a little and you have a little arthritis, you might make all of your pain go away. Some of my patients that have severe arthritis, they'll lose 5 or 10 pounds, they'll still hurt, so there's still other treatment options. Low impact exercise is key. So here's too much exercise. So I'm not asking people to do a triathlon. Here's no exercise. This is laying on the sofa. Both of those are bad if you have knee arthritis, but there's a huge gray zone in between. So you have to do something. And if you think about it, most people, not everybody, but most people will tell me, probably most of you after sitting here listening to me for 45 minutes, when you get up, your knee's going to hurt, everyone's going to stand there and be stiff. So once you get moving, your knee feels better. So all the patients that I see that exercise a lot, they say, yeah, I get up in the morning, my knee hurts, but once I get moving, I feel better. I have to keep moving. So that's the key. So if you exercise every day. And if today's a good day, exercise more. But if today is a bad day, just exercise a little. Try to do something, because something is better than nothing. And the other thing that I get asked a lot is, can't you scope it? That was really common in the 80s. So a scope is the surgery where we make 2 small incisions, go into the knee with a camera and a few small devices and trim that up. It's great for a meniscus tear that happens from a sports injury. But what we thought was a good idea in the 80s, where we'd go in and wash out the knee, doesn't work really well. Most people get worse because your knee has 3 millimeters of cartilage. Underneath that 3 millimeters is bone. So if you have 2 millimeters left and I scrape it down, guess what? Now you're bone on bone. Because it's not like the old cutting board that was passed from generation to generation in our family. If I had a 7-inch block of wood that was really beat up, I could take it to the garage and belt sand 1/4 of an inch off. Now I get 6 1/4 inch of a block of wood. It's brand new. The knee doesn't work that way. So we try not to scope the knee unless there's a very, very specific, narrow indication. This is important. Old is not bad. In America, for whatever reason, everybody thinks old is bad. You go to many other countries and the old, they're revered. They're special. There's a lot of respect there. So an old knee is not a bad thing. An old knee is like your Model T Ford. It takes a little bit longer in the morning to turn the engine over, makes a little bit of noise going down the street, doesn't go as fast as the new car, but it still gets you to where you're going. So don't think that just because you have arthritis, it's a bad thing. It's just, it comes with the territory. But treatment, and this is one of those things I want everybody to take away from this if you haven't done enough for your knee arthritis. So the top 3, you all have control of those things. These are all in your power. So 1, exercise. We'll go over a few, but exercise and strengthening are key. They will lessen your pain. Studies show that if you can strengthen your quad, which is the muscle above your knee, this muscle here, you can reduce pain by 40%. The other thing is weight loss. Weight loss is amazing for decreasing pain. And I harp on it all the time, and patients hate it because I've been this weight since high school. I do exercise a lot, I eat healthy, but when my patients that have struggled with weight for years hear it coming from me, a lot of them give me a hard time. Oh, it's easy for you. It's hard to lose weight, but if you do it, I have enough patients that come back and say, I did it. I did it and I feel better. That's the reason I keep pushing it, but it will lessen the pain that you have in your knee. And over-the-counter medication. So Tylenol and other anti-inflammatories like Motrin, Advil, and Aleve, if there's not a reason for you to take it. So anybody that's concerned if you're on things like Plavix, Coumadin, all the other anticoagulants for your heart or for your brain, you have to check with your primary first. Things that are in my control, we can do prescription medications. We can give you injections and then braces. I saw a couple people walking in with braces. We'll get to that. And then the other stuff. I had a few people stop me and ask me about others, so I'm going to try to cover all the others. Probably won't get to all of them, but most of them. So my top 3. Walking is great, but a lot of people tell me it hurts when I walk. So walking is about 1.5 times your body weight every step. So if you can't walk, get in a pool. If you don't have access to a pool, get on an elliptical. It's like walking, but you don't get the pounding. And if you can't use an elliptical, try to get onto a bike. A stationary bike is a great way. Sit on, recumbent, doesn't matter. Whichever one's more comfortable, you just want to pedal. And start with just 5 minutes a day. That's the big thing that I ask with a lot of my patients is just to try. So if Monday, Wednesday, Friday, they get on a bike for 5 minutes, they think that's silly. But in reality, I asked them what they did last week. And they said nothing. So, well, 5 minutes is more than nothing. And it's not 30 minutes, but maybe in 2 months we can build up to 30 minutes. So start somewhere. Usually the first week or 2 hurts. But my patients that decide it's always January 1st, I'm going to go to the gym. New Year's resolution. I went to the gym, worked out with a trainer. I couldn't get off my sofa for 2 weeks. So don't go overboard, but you want to make a lifelong change. The other one is strengthening. So this exercise, and it should be in the packet, is super simple. Everybody has a leg, everybody has a floor. Lay on the floor. The reason in the picture you bend the back knee is to take some of the pressure off the back. And then what you'll do is you just lift the leg up and lift it down. Up, down, 10 times. And I have my patients do it actually in the office with me because I'm in the office Monday, Wednesday, Friday. So I tell them that if they did 10 with me in the office, they're done for the day. That next day, Wednesday or Friday, they have to do 10 more for the week. And then the week after, 20, the week after, 30. When you get up to 50, most people tell me the knee felt better. But the big thing that's in a lot of people's control is the weight loss. If you don't know what your BMI is, just calculate it. When you go home on your phone, you can Google BMI, body mass index, and figure out where you're at. But I mean, it's scary, but it is a huge reason for medical problems and conditions. We're great at lots of things. This is not a chart that we want to be at the top. So compared to all other countries, we have one of the highest obesity epidemics in the world. So you want to try to get that down. And people say, well, does it matter? Does it really affect my arthritis? Yes. So a normal weight person, the risk of arthritis in their lifetime, 16%. An obese patient, double that. Now, if you get rid of the weight, unfortunately, the arthritis is already there. It's not going to disappear, but you're going to hurt less. So the earlier you start, the less pain you're going to have in the long run, and you can slow down the risk of progression of arthritis. I'm not a dietitian. I'm not a nutritionist. So I've told people things over the years. The big thing is diets, for me, listening to people, they're crash diets. I hear it all the time. I went on Weight Watchers, I lost weight, I gained it back. I did Atkins, I lost weight, I gained it back. I did this one, I gained. So don't go on a crash diet. Change the way that you eat forever and try to lose a little bit of weight. Don't set a goal weight. So I always tell my patients, give me a pound a week. Most people can lose a pound. In a year, that's 52 pounds. And that's a lot more reasonable for people than trying to set a goal weight and weighing yourself every day, because it's going to fluctuate with your clothes and water weight. So just weigh yourself once a week and figure out where your issues are. For some people, it's too much, it's snacking, so figure out where your little thing is. But the 2 things that I want to talk to people about, the plateau, because my patients, when we're watching their weight decline before surgery, everybody hits a plateau. They all say, I hit this point, I'm eating what I'm supposed to eat, and I'm exercising, and I just stop losing weight. Well, that's great. You just became a more efficient machine. Just everything that you do, going to the bathroom, getting the mail, going to work, going shopping, because you weigh less, you're burning less calories. So now you have to do one of 2 things, or both. You increase your exercise, or you lower the amount of calories that you eat. But the plateau is a normal and a good thing, because it shows that you actually have become more efficient. But don't be surprised. I have patients that come in and they say, guess what, I lost 10 pounds. My knee feels better, and my back. And my cardiologist took me off one of my blood pressure medicines. And my other primary took me off one of my diabetes medicines. So all of those things are factors, and you can actually make yourself healthier by doing all those things to address each of those problems. Over-the-counter medications. So Tylenol, ibuprofen, naproxen, and we have a whole bunch of prescriptions that we can use. The thing that I want people to remember, though, is that when you use these medicines, they take a little time to kick in. So the analogy that I like to use in medical school, everybody sees this because this is the therapeutic range of most antibiotics and most drugs. They don't work right away. So the mistake that I hear from a lot of people is, oh, I took Tylenol once, it doesn't work for me. And I took ibuprofen once, and it doesn't work for me. Well, if your primary gave you a prescription of an antibiotic for 10 days, and you took one pill, and you called them the next day and complained that you were still sick and that antibiotic didn't work, you want another one, they would laugh at you, and they'd say, well, stop, you gotta take it every day. And that's the thing that I have people do with Tylenol or an anti-inflammatory. If you hurt, and I don't want you to take medicine for a long period of time, months and years, but if you hurt today or this week, take it for a week. And if you take it for a week, every time that you take it, you're building up those blood levels of the drug, and then the pain and the inflammation go away. And then you might be in less pain for 2, 3, 4 months. But when you have a flare-up, you take it again for a few days. So I like my patients to take these in little mini bursts and then stop those drugs. But the narcotics are bad. And I've harped on this for a decade, and people always thought I was the mean guy, and I don't want people to be in pain. So I don't say take nothing. There's just other options, and finally we're starting to realize, and the rest of the world has realized, that there's an issue. 99% of Vicodin in the world is used in our country. 80% of Percocet in the world is used in our country. So if you have knee pain, you don't need a narcotic. That's not the first line treatment. So I always kind of tell my friends that if you and I went duck hunting and you were out in your waders and I showed up in a tank, you would kind of laugh at me. It's a little bit overkill taking a duck out with a tank, and it's a little overkill to use a narcotic for knee pain. So start with the other medicines, and you may find that after 3, 4, 5 days you feel better, because we know that patients that are on narcotics before knee replacement surgery, whether or not it was because of their neck pain or their shoulder pain or their back pain, but if they take narcotics regularly and then have surgery, they have worse outcomes. They don't do as well. Their pain is not relieved as much. They have more complications. They have more revisions. Someone's going to ask why. I don't know. We don't know yet why, but we do know that it is a factor. So even my patients that are on high-dose narcotics before surgery for other reasons, I try to wean them down before we do surgery. But injections. So cortisone's a great option after you fail pills. So pills, exercise, strengthening, all first-line treatments. If that fails, cortisone's a great option. It reduces pain and inflammation. A few people asked about the lubricants. I only have a few of these. Someone else showed me another one. There's a lot of brands. There's Coke, there's Pepsi, there's RC Cola. I mean, you go to Baskin Robbins, you got lots of flavors. They're all variations on a theme. They're all what we call visco supplements. So these are lubricants that are meant to lubricate the remaining cartilage in the knee. They do not reverse arthritis. They do not make your cartilage healthier. They do not prevent arthritis. There are a lot of misconceptions that people hear sometimes. But it may improve the pain in about 40% of people. So that's the honest statistical truth, is that a lot of studies show it doesn't help everybody, and it usually helps people with early arthritis. So even our academy doesn't recommend using it on a regular basis, so it's just another option that we have to control pain. As far as the ultrasound or the x-ray, it's not necessary for the knee. A lot of people ask about that also. Do you need the x-ray or the ultrasound? You do not need it for the knee. In the small joints of the hand, the foot, we can't see them. People do use it in the knee, but it's not necessary. Braces. I saw a few people walking with braces. If they help you, they're good. If they don't help you, you don't need to wear them. I have a lot of people walk in with a Nordstrom's bag. They have the question, they start pulling out brace 1, the copper, brace 2, the magnets. This one's got the straps, this one's got the hinges. And they said they've tried them all. None of them help. Do they need them? The answer is no. There's not a brace that will prevent arthritis. There are some braces that people wear that make them feel better. And a lot of times it's the simple little slip-on knee sleeves, the neoprene ones, and it makes you more aware of where your knee is in space. So if you wear it, you're more likely to be aware when I turn or pivot not to twist my knee bad, or when I squat down not to bend it too much. So if it makes you feel better, wear it. But if you tried it and it doesn't help you, don't feel that you're making your knee worse. All the other stuff. So I brought the cane for 2 reasons. So if you can't hear me for a little bit, I'll speak louder. But if my left knee hurts, who thinks the cane should be in my left hand? Raise your hand. And if my left knee hurts, who thinks the cane should be in my right hand? And who didn't raise their hand? So it should be in the opposite. And it doesn't make sense to a lot of people, because if this knee hurts, everybody kind of leans on that side. The center of gravity is right here. So if this knee hurts and I lean over that knee onto the cane, I just put more weight on my bad knee. So it's awkward for a lot of people, but if you put it in the opposite hand, that as I walk with my good leg, and then I walk with my bad leg, I can lean away from the bad leg and take the weight onto my hand off my bad knee. And it's an awkward thing. It's sort of like learning to do the waltz. It takes a little bit of time, so practice at home. But by people doing that, I have it in the office every day. I watch people get up, and I say, give me the cane, take 2 steps, and and they go, oh, it feels better already. So just that one little trick. The other one, whether or not you're using the cane, that I get asked all the time, are stairs. So the thing that we always tell people, up with the good. So if you have to take them one at a time, it's up with the good, down with the bad. So this way you're always leading with the bad. And one of my favorite therapists here, she has a great way to remember it. Good ones go to heaven, bad ones go to hell. So that way you'll never forget it. She teaches all of her patients and they always remember. But that'll prevent, if you need to use those stairs, that's the best way to take it. So creams, patches, Voltaren Gel Flector, those are anti-inflammatory patches or creams. They do help some people. All of the over-the-counter stuff, if you use it and it makes your knee feel better, that's great. You're just, again, treating symptoms. Glucosamine chondroitin, there's not a whole lot of strong evidence that it really does anything for arthritis. That being said, if you do it and it makes you feel better, that's okay. We don't know of any harm. So my feeling is, if it doesn't cost you a lot of money, if it doesn't hurt you, and you feel better, then it's a good treatment for you. A lot of herbal remedies, people have used arnica, turmeric, they're options. Acupuncture, I have some patients that use and swear by it. It makes them feel better. And diet, people always ask about anti-inflammatory diets. There's not a whole lot of proven stuff for me to say you need to do this or try that or eat this. But if you try it and you feel better, then it's a good option for you. This is my tip. So all of my patients, when they travel, 4 things I tell them to bring. A Ziploc freezer bag. In the Ziploc freezer bag, put a bottle of Tylenol, and if you can take an anti-inflammatory or anti-inflammatory of choice. This way you don't have to spend $40 for a bottle of Tylenol at the hotel with 3 pills in it. But you have it, and you have your anti-inflammatories. And most people in the hotel can find an ice machine for their sore knee, but they can't find a bag. So now you have a Ziploc freezer bag. And the other one is go to REI or one of the local outdoor shops and get a collapsible hiking pole. And this way, if you need it, it is in your luggage. So I have patients that are always going all over the world, traveling to places that I'd like to travel to when I retire. And I say, bring the pole, and they'll come back and say, yeah, I went to Machu Picchu and I was able to take the cane and my knee hurt, but I made it through. I'm glad that I had it. So just throw it in your luggage and forget about it. Now, this is the other one. People always ask, is it going to get better? I'm sorry. Your arthritis is not going to get better. It always gets worse. But it may not get worse quickly, and you may have good days and bad days. So the stock market is sort of predictable over a 30-year period. We know it starts there and it goes there. But we know that today something good happened in the world and it goes up, and today something bad happened and it went down. But even the guys on Wall Street, something happens and they have no idea why it went up or down. So your knee's the same way, just reversed. So your knee's going to get worse over time. You're going to have good days and bad. Some days you're going to do a lot, you're going to expect it to hurt and it doesn't. And other days you're going to do nothing, you'll wake up and it's killing you. So don't try to figure it out. Just if it hurts, treat it, but just know that over time it will get worse and we deal with it down the road. So can you scope it? This is a question that we kind of broached on before, but I get asked all the time. This is a pretty normal looking knee that if you look at the picture on the left, the cartilage, the little ball-shaped thing up top, that's the thigh bone. The bottom is the shin bone. Pretty smooth looking cartilage. And then you look at the second, that's the other half of this person's knee. That's a torn meniscus, it's frayed. And the third picture is after I've resected it. The problem is, no matter how bad your meniscus tear is, if you don't have the cartilage above and below, and I clean up the meniscus, you're still bone on bone. So you still hurt. So that's the reason why when someone comes to us and says, but I have a meniscus tear, yes, But by fixing the meniscus tear, it's not going to fix the fact that you're bone on bone. So that's the reason we don't typically scope arthritic knees. And then partials. I get asked about this a lot. Partials have been around for a long time. They are a little less invasive because the knee has three parts. There's a kneecap part, there's an inside or medial part, there's an outside or lateral part. So the partials replace just that, just 1/3 of the knee. And patients that have a knee replacement on one side and a partial on the other, they all tell me the same thing. My partial feels more like my normal knee. And you'd expect it to because it only replaced 1/3, not 3/3. It is a slightly shorter recovery. It's a slightly shorter longevity, meaning that if you have a knee replacement on one knee and a partial, a lot of times the partials don't last as long as a full knee replacement, but you can still get arthritis in the other parts of your knee. So for us, if you put a partial in a very young person that only has arthritis in one spot, you can predict that they're probably going to get arthritis in the other parts of the knee as they get older. But if you have arthritis in other parts and we replace just 1/3, those patients come back and say, but my knee still hurts. It's a little better. So that's where we would err on a knee replacement. So don't feel that a knee replacement's bad. It's just different. And if you do a partial, surprisingly, you convert it to a total, you'd think it would just be like any other total, but the results are not as good. So that's why we really have to pick and choose carefully who are good candidates for a partial, because we don't want to put you through 2 surgeries. This is a partial. So this is what we call a medial partial, where the outside half of this person's knee and the kneecap joints were fine. So there's just a metal part and a metal part. Sandwiched between is a plastic part. And that makes up for the arthritis on the inside of the knee. But we can also replace the kneecap joint. So you can see the picture on the left is a severely arthritic kneecap joint. The kneecap is almost 50% out of the way, what we call sublux, and almost dislocated. And then when you go in there and shave off the bad cartilage and realign the knee, you've replaced their kneecap joint, but the thigh bone, shin bone areas were okay. So those are partials. But this is sort of the stuff that everybody always wants to know. Is there anybody that needs to stand, stretch a knee? Everyone's okay? So this is the knee replacement stuff. So this is the stuff that I try to tell all my patients about, because the more information that you have, the more you understand what you're getting yourself into, the better you're going to do. Most common question I get, do I need it? Well, luckily, no. The cardiologists are different. That if you showed up in the ER with a heart attack and a blockage in 2 arteries, guess what? You need a stent or a bypass. You're going to die otherwise. Luckily, no one died from arthritis. But it can lead to other problems where people just don't like their quality of life. So it's an option if you're not happy with things. And we're always going to tell people, you'll know when it's time. And some of you may have heard that. And it's hard to figure out what that means. What do you mean, I'll know? You'll know when it's time. I try to narrow it down, though. So if you've done an exercise program, and if you've lost weight if you had to, and if you tried pills or shots, that's first-line treatment. Everybody should do that first. I have patients that say, I don't want to do that, I want to have surgery. I don't like those pills, they have lots of side effects. Well, the risks of surgery are a lot greater than the side effects of Tylenol. So I'm a very big fan of try the simple things first. Second thing is quality of life. Because if you can do everything that you want to do, I have guys that come in with knee pain that are surfing and playing golf 5 days a week and tennis the other 2 days, and they're hiking up mountains. I can't make that person better. I could make their x-ray better, but I can't make them better. So quality of life is within reason for a knee replacement. It's not a normal knee. The way that I describe it to a lot of people is that if your normal knee is a 10 on a scale of 0 to 10, a great total knee is an 8. So if you're a 7 or an 8, you're not going to be happy with the outcome of a knee replacement. But if you're a 3 or a 2, and we put you from a 2 to an 8, you're ecstatic. You've got your life back. The other thing, and luckily rarely do I see this, but you have to be medically stable. It is a big operation. So we don't want to put someone under anesthesia and through the rigors of surgery if you can't tolerate it, and you have to do the therapy. It's a thing I tell people over and over again. This is so important that this surgery works really well if I do my job and you do yours. If neither one of us do our job, the knee does not work well. And I stress that because I see a lot of second opinions. I see a lot of people that come to me with a knee replacement that was done somewhere else. And 99% of the time, the knee was done well. It was aligned well. It was positioned well. It was sized well. But they didn't do the therapy and they got stiff. And if you've talked to some people, the worst stories that you'll hear are the people that had a stiff knee after surgery, and they tell you, my knee's worse now than it was before surgery. They're miserable, and there is no going back. And I tell them all the things that I'm going to tell you tonight, and the thing that I hear from everybody, which is the reason I stress it, is they say, why didn't someone tell me this before surgery? Why didn't they tell me I had to work harder? I would have worked harder if I knew. And I don't know. Maybe they did tell them, maybe they didn't hear it, maybe they didn't stress it, but it's really important that you have to give 110%. And I tell people that if you're not willing to do the therapy, don't have the surgery. If you're going to have the surgery, you have to be willing to do the therapy, and that's what's going to make the knee work well. Now, you're probably ready if you have trouble getting off the toilet. Count how many steps. None of my patients that don't have knee pain count. They'll come in and tell me, I have 17 steps in my house, separated by a landing. So those are things that only people with knee arthritis, sometimes hip arthritis, deal with. And even today, I mean, everyone's going to get up and dinner. You stand up and everybody starts walking to the front of the restaurant, and you're stuck there holding onto the table because you got to loosen up your knee and kind of get it moving. So those are all things that people run through if they have knee arthritis. It's common. Everybody gets it. The medical things, the things that I think about that you don't necessarily have to think about, but we'll talk about, is if you're a smoker, you got to quit. Luckily, Southern California, there's not a lot of smoking, but it increases risks of infection, wound complications, blood clots. You got to quit. Diabetics, there's a certain number that diabetics follow for their sugars, and anything over 7 increases their risk of complications. So that's a modifiable problem. We fix that first. The weight is a big factor that people that are overweight, over a BMI of 33, your complications increase. The last thing you ever want to deal with is an infection in a total joint. It's a disaster. So anything that we can modify, we do. You have to have good teeth, and people wonder about that, but the mouth is a source of infection. So if you have a rotten tooth or a cavity, that is a source of mouth bacteria getting into your bloodstream. And those bacteria love artificial things. So they like heart valves, and they like knee replacements. So if you have a cavity, we fix that first before you have a knee replacement, just so you don't develop an infection in the knee from the mouth. Good nutrition is really important too. So we check this lab called an albumin, because people think about malnutrition as people, a lot of times over in Africa, when some of these epidemics, people look really skinny, but you can be heavy and you can be malnourished. And if your protein stores are low, you actually can't heal as well. So they have more wound complications. And we have to have good tissue. So things like psoriasis, some people have swelling problems where the skin is not healthy, that if you make an incision through that, you increase the risk of a complication. So these are all the things that I think about, separate from the things that you think about. So big operations, 600,000 are done every year in the United States. So it's a really, really big, and it's growing fast. 3.5 million knee replacements we anticipate will be done every year in the United States by the year 2030. So I got my work cut out for me. But there's lots of people that are needing this, and the good news is they work well, which is why people keep having them done. So once you've decided, if you say, okay, I've done the pills, I've done the exercise, I've maybe had shots, and I'm hurting, I'm not happy, my quality of life is not what I want it to be, I'm ready for knee replacement, couple things that you need to do. Talk to your primary, because they would give you a once-over to make sure that you're healthy enough for anesthesia. If you have teeth problems like we talked about, you go to the dentist, take care of that first. And if you have other issues, a lot of my patients, if they've had pacemakers or stents, we get them into their specialist first because they might want to do special tests. My office, Veronica, takes care of just about everything that I do except operate. So she's going to call you, she's going to get your insurance authorization, she's going to set up your pre-op appointments, the date of surgery, she's going to send you all the stuff that you need to read and fill out, and then set up your appointments for even after surgery. And then you're going to come in for your pre-op. So usually 2 or 3 weeks prior to surgery, you come in, you meet with my nurse. We do a wash that you do on your skin and your body before surgery. Again, another way of decreasing the risk of infection. She'll give you instructions for both before and after. We give you the after again after surgery. We try to be very repetitious because people lose and misplace things. You'll meet one of our orthopedic fellows. So they'll go over your exam again, talk to you again. We do labs, EKG, and a nasal swab, so anything your primary didn't do. And we always tell people, when you go to the hospital, look for the cafeteria, because you need to go to the left of that. So that's where that sign is. So you'll look at the cafeteria. The room you need to go is just to the left, and they'll do all those tests. We do a nasal swab, and the reason is that certain people are carriers of MRSA. So people have heard of staph infections, and there's a small group of people in the US, about 4 or 5%, that are carriers of MRSA. And if we don't know that, we don't give those people the correct antibiotics. So we do a swab on everybody. And if you come back as a carrier, you're not sick, you're not ill. It just means that you need a very special antibiotic. And we wouldn't know that otherwise. So that's the reason we do the nasal swab. And then you see the account rep upstairs, which checks your insurance and goes over any other paperwork that you need for the hospital. Then you come in for surgery. So this is the big day. Everybody's nervous the night before. Most people don't sleep well. That's normal. But you'll get up early, you'll come in, nothing to eat or drink except certain medications. We will tell you, take your medications, and that'll be given to you on your instructions before surgery. Those you'll take. And then you'll come in usually about 2 hours prior to your surgical time. And then when you come in, you're going to come to this room downstairs by the cafeteria. This is the waiting room. You'll check in, and then they'll take you back, but it's where your friends or family will wait. There's an information board, so they can follow you through the whole process. Nowadays, they can watch and say, okay, she's in the holding area. Now they're in the OR. Okay, now they're in recovery room. Now they're waiting for a bed, so you'll know where they're at. And then I will come out and talk to your friends or family after surgery to let you know how everything went. And it's usually about an hour after that before you would wake up. So from there in the morning, you'll go back to a pre-op holding area. So here we keep you busy. You'll see a pre-op nurse. She'll put you in one of our lovely hospital gowns, check your vital signs, check your paperwork, do labs, and then pre-op meds. So this is a little cocktail. This is a cocktail of a pain pill. This is a cocktail of an anti-inflammatory. It's a cocktail of Tylenol. It's an anti-nausea pill. I'm not a genius. I didn't come up with it. Everyone in the world's using some form or fashion. But what we know is that if you can treat pain before it starts, and a lot of these medicines take 2 or 3 hours to kick in, you will have less pain afterwards. So we really try to start the process early. While you're also there, you'll see me again, you'll see my fellow, you'll see the nurse that works with me in the actual operating room, and then you'll also see the anesthesiologist. So the anesthesiologist will go over your history, they'll talk to you about the anesthesia, and they do a nerve block. So the nerve block will control about 60-70% of the pain in your leg. That reduces the pain that you feel during surgery, so you don't have to go as deep. And it also gives you pain relief for about 24 hours after surgery. So again, if we block the pain before it starts, the pain never gets as bad. And this is not a new thing. I got involved with a lot of the pain stuff about 10 years ago. And if you look at the very bottom, The Lancet's a very famous medical journal. This was published in 1913, over 100 years ago. So if you study history, a lot of times you can learn things that we forgot about. So we now know that the preemptive analgesia, of giving you medicine to prevent pain before it starts, your pain never gets as bad afterwards. As compared to the old days where you'd have surgery, you'd wake up in horrible pain and they'd just pump you full of morphine until you'd throw up. That's not good. It doesn't help with recovery. So we do this all before surgery. But this is the important thing that I like people to think about, because I am very big into making sure that people's pain is controlled. But that doesn't mean pumping you full of narcotics. So the central sensitization. So that is giving a little bit of narcotic, but blocking it with the numbing agents, both in the knee and the nerve block. Inflammation is controlled by anti-inflammatories. And then the tissue injury, we control with other stuff, managing the soft tissue well. And the other big thing is anxiety. And that's where I really spend a lot of time teaching all of this, because if you know what to expect, then you're less likely to be anxious. And it's interesting, they did a study in one of the nursing journals where they had two groups of patients having knee replacement, exact same thing, but one group had this formal process like we're doing now. The other group was told you're going to have a knee replacement. And the group that had more information, they all perceived that their recovery was easier, that they had less pain, that they had a quicker recovery. And when they looked at how much narcotic the groups used, it was the same. So people can feel better just by getting the information. When you come back to the operating room, this is one of the rooms you'll see. We have 3 rooms. I have a great staff that works with me. So you have the trays on the back. We have all the implants. Everything's made sterile. We use the spacesuits. People hear about the spacesuits. Some of that is for our protection. It's also to protect you. We don't want to get our bacteria anywhere in the room. And we also have these special rooms, that back wall that you see. There's actually air that circulates faster than any other operating room. So these are super clean rooms to lower the bacterial load in the room, which lowers our infection rate. But a knee replacement, hopefully everybody had a chance to see in the back. I like to call them a resurfacing, because when you see the implants, you get an idea now. I think a lot of people think we chop your knee in half and we drop a hinge in there. And we have that for complex cases. But what we do is just shave off the end of the thigh bone, top of the shin bone, and put the metal and plastic. So you've resurfaced the bad cartilage with metal and plastic. You preserve your ligaments. So this is the thigh bone part once we prepare the bone. normally takes off about 8, 9, 10 millimeters of bone, so a small amount, and then it gets capped with that piece of metal. The shin bone gets planed flat, about 2 or 4 millimeters of cartilage gets removed, and then the metal part with plastic goes inside there. And then the last part is the knee cap. So on the back half of the kneecap, we shave that flat and put a plastic button. So when you bend and straighten your knee, it's the plastic that rubs on the metal. Now, one of the things that I like to do afterwards is I take a picture. So when you're all done and the dressings are on, I bend your knee up and I take a picture and I give that to you. And I let you know that even though it hurts, that you're not breaking anything. You're not damaging the implant. And that little piece, I think for a lot of patients, lets them push through some pain because they're confident to know that they're not going to hurt the thing that was just put in. And that one little picture, when I started doing that, it was amazing how much easier people got motion without changing anything that I did in the actual operation. So it's just that peace of mind that you can do it. So after surgery, you go to recovery, and that's what you're going to see. You're going to stare at the ceiling and come to, and the nurses are going to be on top of you checking your vital signs. But this is where you'll be. They're going to make sure that you're comfortable. They're going to make sure that you can take ice chips. They're going to make sure that you can have some crackers, and you'll be there for about an hour, and then we'll get you upstairs. So the day of surgery, you are getting up. You're going to do therapy. And a lot of people, they look at me and they say, no. I say, yes, you're going to get up. So the quicker that you get moving, the faster you recover. So we do start with bed exercises the day of the operation, stand, and if you're comfortable, you can walk. We put you on a pain regimen. So it's not that you just don't get narcotics. It's that we put you on Tylenol around the clock. I put you on anti-inflammatories around the clock. We put you on a nerve pill around the clock before you ask for it, because if we can beat the pain before it gets there, the pain never gets as bad. And by doing that, people use a lot less narcotic. Everybody tells me now, compared to 5 years ago, if I've had patients that had a knee replacement before we did this, they all said, I felt better, I was less constipated, I was less nauseous, I was less foggy, and I recovered better, and I only used like 10 or 20 of the narcotic, where years ago people would just pump themselves full of narcotic and they would feel terrible for a month. So we try to get away from that. The day after, so post-op day 1, I see you in the morning, we change your dressing, we do more therapy, once in the morning, once in the afternoon, and 90% of people, if you're comfortable, you can walk the hallway, walk up and down the stairs, you get to go home. Sleep in your own bed, eat your own food. You don't have someone knocking on your door at 2 in the morning to check your blood pressure, because my blood pressure would be high if someone woke me up at 2 in the morning. So go home. The motion machine, this is the other question I get asked all the time. No, we don't use it. Old stuff. It was actually introduced down the road at Sharp Hospital, Dr. Coots, 1982. So do you want anesthesia or a knee replacement or anything from 1982 if you can have something that's more 2017. It's an old way of treating the knee, because before that, in the 70s, if you had a knee replacement, you probably spent 2 or 3 weeks in the hospital, but you woke up in a cast, you didn't bend your knee for 2 weeks, and then after 2 weeks, you went back to an operating room. They took the cast off, they bent your knee, they did what's called a manipulation, and then you started doing your therapy. So it's sort of a no-brainer, cast versus motion machine. Who has better motion? No-brainer. But nowadays, since we get you moving early, you using your muscles will make your knee recover better than laying in bed and being on a machine. So we don't use those anymore. Motion, this is the other question I get. I get a lot of people tell me, I can bend my knee back all the way. Most of the implants on the market now, they all will get more motion than you will ever get. They can usually get about 140 to 150 degrees of bend. Most people never get that. So if you have a very stiff knee before surgery, you're not going to get 130. But if you have a lot of motion and arthritis, you have a better chance of getting that motion. So how much motion you have going in is a really good predictor of where you're going to be. An average knee replacement, when you look all over the world, all different implant designs, about 115 to 120. The exercises, like we talked about before, are key. But what you describe as stiffness and what we measure as stiffness are two different things. I have a lot of people that after surgery have 10 degrees more motion than when I met them, but they will say my knee is stiff. So a lot of times it may feel stiff, but it will still move more. And a lot of the stiffness early on is inflammation, and that goes away over a number of months. 2 weeks at home, you're doing therapy. You're responsible for this. We tell you therapy is really important, but I always have my patients stop and think about it. Yes, therapy is important, but don't go bonkers, because your knee does two things. Your knee straightens and your knee bends. That's it. So you don't really need a therapist to tell you what to do with your knee. You just have to straighten and bend it. Your therapist and me, we're there to help you because sometimes one of those exercises is hard, so we might show you a variation on how to do the straightening or a variation on how to do the bending. The Tylenol and Celebrex, you'll take it home, or some anti-inflammatory. Those medicines are around the clock for 2 hours. That really controls the pain well. And then we use the narcotic just for breakthrough pain only. That is the option of last resort because that has all of the side effects. Icing elevation, as simple as they sound, they work a lot. And really a healthy, high-fiber diet because anesthesia, pain medicine, dehydration all lead to constipation, and you need to heal. You're going to burn through so many calories healing, so eat and eat well. You'll see my nurse back at 2 weeks. We take out the staples, we check your motion. You should have 100 degrees at that point. If you don't, I'll call you out on it, she'll call you out on it. We want you to work harder because the more work you do in the beginning, the easier your recovery is. The next 2 weeks at home, more therapy. More and more therapy. You'll go from home therapy, you'll feel good. You'll start to go to outpatient therapy. You'll go from the walker to the cane to nothing. And everybody's off the narcotics at that point. Usually most people decide at that point the Tylenol works better for me or the anti-inflammatories work better for me. So most people pick one or the other. I'll see you back again in a month. We check x-rays, we check your motion, and then almost everybody walks in with the cane. Everybody that I see. And I asked them, are you using it? And they said, no, I thought I was going to get in trouble, so I brought it anyway. But you don't need it at that point. So when you're okay going off of it, you can get rid of it. We'll go over some things that are common at 1 month because you're better, but you're not fully recovered. Most people can drive 4 to 6 weeks. So if it's your right knee, 4 to 6 weeks. If it's your left knee, by 4 weeks, most people are driving the car already. 1 to 3 months is just more therapy. You're getting back to your normal life. You're walking, you're exercising, you're doing outpatient therapy, and everything's getting better day by day. Your motion's getting better, swelling's getting better, you're sleeping better. Patients that are still working, you're going back to work. Sorry, but you do have to go back to work if you're still working. But those people are starting to get back into living their normal life. I see you back again at 4 months. We check more x-rays, check your alignment. We talk about going back to the dentist because I do recommend that you take antibiotics before you go to the dentist for the rest of the life, just because it lowers the risk of mouth bacteria getting to your knee replacement. It's extremely rare, but it does happen, so we do recommend it. Now, all the scary things, these are all bad. Luckily, they're all rare. So infection, the risk in the US is between 1 and 2%. Here, our risk is less than 1%. You can have a wound healing complication, which is again why we look at making sure you're as healthy as possible going in. Blood clots are a concern, so we do get you up and moving, put you on squeezers, put you on blood thinners. We typically use aspirin unless you have other risk factors. We put you on stronger medicine. Blood loss is very rare nowadays. Luckily, the risk of needing a transfusion is less than 1%. So you do not have to donate blood ahead of time. All the other things are really rare. Fracturing, injuring ligaments, dislocating the knee, they're all extremely rare. But if there's a problem, it can be revised. So the other pictures that you saw, the difference that you notice here is that post that goes up and down the leg. So if the first knee replacement fails for any reason, we can put another knee replacement in, but we have to add to it. So if you had a cavity, that's just like a little shaving, like an arthroscopy of your knee. If you had a crown, that's like a knee replacement, where we actually cap your tooth with something artificial. But if that crown fails, and now you have an implant, the doctor put a post into your jaw and then put an artificial tooth on top of the post, and that's what a revision is like. Normally, after surgery, everybody has some pain and stiffness at night. It's normal, it's typical. It's more because your knee's not moving the first 2 or 3 weeks at home. Once you get up and move, it goes away. The knee will feel warm for a couple weeks and a couple months in some people. That's normal. The knee will click a lot more in the beginning just because it's swollen. And when that metal touches the plastic, you'll hear it or you'll feel it more than you'll hear it, but most people are aware and it goes away over time. And anytime that we make an incision over the front of the knee for a fracture, a ligament rupture, or knee replacement, the little skin nerves on the outside, they always get cut. You can't see them, they're microscopic, so you'll have a little patch of numbness and it goes away over time. I follow you forever. So, well, as long as you're here and I'm here, we're going to see each other. So every year, every 5 years, every 5 years after that, we keep an eye on it because if there's a problem with the implant, a lot of times we pick it up on x-ray before you feel symptoms. But luckily, most of these implants we think should last 20 or 30 years in most individuals, but we do keep an eye on it. And I want you to get back to a healthy lifestyle. I mean, that's the whole reason for doing all this. We keep an eye on this. So someone says, well, how good is it? We know. And luckily, we know because of Dr. Caldwell. When he started here in 1978, he saw this coming from a mile away. He started capturing data on every one of his hip and knee replacements. And we've continued that. So we actually have over 20,000 joints in our registry here. So when someone says, how did that knee work, or how did that hip work, or how long does this last, we know it because we have it all in the database. We have over 600 publications. The new thing that you may see in the news occasionally is there's an American Joint Registry that only started a few years ago. So there's 1 million patients. Sounds impressive, except there's 1 million joints done in the US every year. A lot of other countries, they started these registries in the 70s and 80s, so we're a little bit behind the 8 ball, but we're catching up. So now we're going to have outcomes. So if you are here and then move halfway across the country and there's a problem with the implant, we will know about it. And that's the important part of collecting all the data on the knee and hip replacements. So that's everything in a nutshell. You guys got everything that I possibly can tell every one of my patients in the office all at one sitting. So hopefully you kind of walk out of here with 2 or 3 things and learned a little bit about knee replacement. But I'm sure there's some questions, so I'm happy to stay. If people are tired and want to stand or people have to run. Thank you for coming. But thank you.